Oh my gosh, we even have Jeff Galbraith. You are with us. That's fantastic. And see a bunch of others. Dr. Yates, Maria, Jermaine, Paul, lots of familiar faces and names. This is fantastic. Thanks for joining us. We have a very interesting talk today. And hopefully we'll have a lot of case discussion because these things, that's what they generate, right? All kinds of discussion. So anyway, here we go. Let's go forth. So thanks for joining Project ECHO. This is an opportunity for case discussion, interdisciplinary expertise. We're forming a community of learning. This is online, distance, and free, totally free CMEs. Next slide. So please, we encourage you to share your cases. Any geriatric topic is fine, even if it's not pertaining to today's topic, but we still love to talk about challenging geriatric cases. Next slide. Just a reminder that everything shared today needs to be confidential and safe and HIPAA compliant. So if you share any information, always make sure it's all de-identified. And also that this is a safe learning environment. We're not going to try to blame and shame anybody. A reminder that case consultations do not create or establish provider-patient relationships between the ECHO panel or for the people being discussed. Next slide. In order to get CMEs, after the conclusion of the hour, click on the link and complete an evaluation. Michaela or John will put that in the chat box towards the end. Next slide. And a little hiccup here is that beginning in January 2023, in just 2 months or so, the Hawaii Consortium for CME will no longer be providing CMEs for us. And so if you want to view and print a copy of your own CME transcript to the end of this year and the whole entire previous year, you have to go online and access them yourself. This is the website, and we'll put that in the chat as well. And there will be instructions in the resource tab of the ECHO website as well. And those transcripts they promised us would be available till September 2023. So you have like 10 months or so to get your CMEs before they're gone forever. Next slide. And of course, going forward for future CMEs, we're going to be working hard on getting those obtained. Okay, and of course, I think you know how to use your chat box and your mute button. Of course, we encourage you to put in any questions you have into the chat box or unmute yourself and share. Otherwise, you can put your name in the chat box as a way of taking attendance. And today, for our hub team, we have myself. I'm the course director for this ECHO Geriatrics Clinic. We have Sarah Tompkison, and you can wave and say hi. Social work, 41 years of experience in geriatrics, health, mental health, and long-term care. Served in a lot of different places, the VA, Hale-Kuike, Central Union, Adult Daycare, and she's now at Straub. And we is Lucas here? I don't see Lucas. Maybe he'll join us a little later. He's a psychologist, clinical psychologist. And we have Mary Gotham, who is a retired public health nursing department from the Department of Health. All right, and I know just from looking at all you guys attending, lots of expertise here as well. So I'm looking forward to this. Okay, next slide. And most importantly, I'm introducing Dr. Susan Christensen. She is a family physician with over 15 years of primary care experience in Hawaii, who realized the challenges faced by older adults. She has an MBA in healthcare administration, and then she returned to fellowship training to learn how to best care for geriatric patients. And so she's been with us a little over a year now. She hopes to influence change within the medical business environment so patients can afford needed services, doctors can earn a living, and the well-being of both remain paramount. She is currently a second-year fellow. And without further ado, we'll have her share her slides. Thank you.
Thank you so much, Dr. Wen. Just give me a moment to pull up my slides. Okay, is everyone able to see my slide? Yes, and everyone can hear me okay? Excellent, good. So yes, thank you, Dr. Wen. Good afternoon, everyone. I am so honored to be with you this afternoon to share a personally and professionally transformative patient care experience with you. Ooh, here we go. Maybe not, there we go. Good. For those in the audience who are not familiar with the Our Care, Our Choice Act, it is Hawaii's law authorizing medically assisted death. We are currently in the 4th year since this law went into effect, and it still remains controversial. My own perspective on the issue was shaped early in my career, highly influenced by Dr. Jack Kevorkian, who was practicing at the time, and he was portrayed as the evil Dr. Death, going around killing off old and sick people. Needless to say, my perspective on this topic has changed over time, and getting to where I am today was not a journey that I was planning to take. So let's start by meeting Peggy. She was a vibrant widow who lived in her own home on the windward side of Oahu. Every time I saw her, she was dressed to the nines, complete with lipstick, a matching handbag and shoes, and even a coordinating eyeglass chain. She was a philanthropist and was involved in community activism. She lived a healthy lifestyle, swimming daily for exercise at the YMCA, and was on no medication at all. Her only diagnosis was pulmonary fibrosis, but this did not limit her activities or her enjoyment of life. Her greatest risk factors for disease were her age and the fact that she had lived with a smoker for decades. Her first significant health concern was when she was 90 years old. She had developed fatigue and a cough that lasted several weeks. Thinking that it was a virus, this was pre-pandemic, mind you, she did not come to see me until she started coughing up blood. Her chest X-ray identified a pleural-based mass, which persisted even after we treated her for pneumonia. A CT-guided biopsy was attempted, but the location was too difficult to be successful. After discussing the best case scenario, that it could just be benign, or the worst case scenario, it could be cancer, Peggy decided that she did not want to know more. She was not going to have any kind of surgery after the failed biopsy was more than she could tolerate anyhow. Even if she did find out it was cancer, she was not going to do any treatments for it. She was feeling fine and went back to her regular activities. I didn't see Peggy for much of the next year and a half, other than for routine checkups. I then started getting ER reports. Initially, she was experiencing weakness, loss of appetite, back pain, and blood in her urine. Imaging did not find a cause for her hematuria, and so she was treated for a urinary tract infection. When that did not work, she went back to the emergency room, where she was found to be anemic. And then the third time, she actually required a blood transfusion. This is when I reached out to her and made her promise to come see me. Peggy was thinking that the hospital was where the testing needed to be done, so if she went there directly, she would get what she needed. However, I held the critical piece of information that the ER did not have access to, which was her undiagnosed lung mass. Once we put these two pieces of information together, the needed test, a CT with IV contrast, was approved, and we found what I feared might be there, a large renal mass. The day we met to go over her results, I was armed with options and next steps, but Peggy had her own ideas. After I told her what she knew was coming, she sat back, smiled, and said these words: "Dr. Christensen, I have had a really good life." But what she said next took me off guard. She said, "I do not want to suffer, Is there any way we can hasten this along? So Empathy 101, the throw pillow rule of thumb. If something you are about to say would look good on a decorative throw pillow, don't say it to someone who is suffering. I am certain I failed the test that day. I probably said something like, well, we have ways of controlling your suffering. What Peggy was referencing was Hawaii's Our Care, Our Choice Act, which went into effect January 1st, 2019, around the time that we discovered her lung mass. Our Care, Our Choice was the 8th law of its kind to pass across the United States. 3 more have been added to the list since then, for a total of 10 states plus Washington, D.C., that now allow some form of medical aid in dying. To access their rights granted by law, patients have to meet these fairly straightforward eligibility requirements. They have to be diagnosed with a serious illness with a life expectancy of less than 6 months. They have to be 18 years of age or older, be a Hawaii resident, physically able to consume the medication independently, it can't be fed to them, and able to meet all of the legal requirements, which we will go over next. All practitioners who may encounter patients with serious illness should be aware of these eligibility requirements, whether or not they are able to act as a certifying provider. Having the ability to openly discuss eligibility with a patient who may request information about these rights can facilitate appropriate and patient-centered care. The legal requirements of Hawaii's OCOCA law are a little bit more complex. First of all, the patient's medical record must contain documentation of 2 oral requests and 1 signed written request to an attending physician who accepts responsibility for coordinating confirmation from a second provider and a mental health provider, completing all documentation and writing the prescription. Presently, only Hawaii licensed physicians, MDs or DOs, are able to sign as attending or confirming providers. A mental health provider can be any licensed therapist, including LCSWs, PsyDs, PhDs, MDs, and DOs. At 20 days between oral requests, Hawaii has the longest mandatory waiting period among all 10 medical aid in dying authorized states and the District of Columbia. The written request must be witnessed by 2 people, neither of whom can be part of the healthcare team, and at least one cannot be related to the patient. A minimum of 48 hours must transpire between the attending physician's receipt of the written request and the writing of the prescription. So as you can see, there's a lot of steps with time delays in between. So back to Peggy. The first day we met to discuss her diagnosis was when Peggy made her first oral request. At the time, I documented it in her record. I had no intention of being the physician who would see her through that journey. Ultimately, however, that discussion marked the start of the 20-day waiting period required by law and the beginning of our journey together. She was still ambulatory at this point and remained in her home. I referred her to hospice, which she welcomed, and they admitted her within the week. I thought, or maybe just hoped, that this would be the end to her request. So if you will indulge me for a moment, I'm going to pause here and talk story about values. So according to life and business coach Tony Robbins, values are the fundamental beliefs that govern our lives. They are our inspiration to act, and they guide our decisions about everything. They embody the person we want to be influencing how we treat others and how we interact with the world. Values are the core of who we are. As important as our values are in defining how we live, so too should they define how we die. We as providers, when we are dealing with patients at the end of life, have an obligation to conscientiously filter our own values and make sure that our recommendations reflect the values of those we are providing guidance to. Does this patient want to be alive no matter what that life looks like? Or does this patient want to leave this world if they are not able to return to their idea of an acceptable quality of life? We also have an obligation to be honest and provide perspective when it comes to a serious diagnosis. Is this patient realistic in their expectations for what can be done for them? Or is this patient unable to see that good things can still happen for them? Okay, thank you for that momentary divergence. I'm embarrassed to admit that for 2 months, I did absolutely nothing for Peggy. Even with regular updates from hospice, reiterating her desire for a prescription, we were in the throes of the COVID shutdown by now, trying to figure out what telehealth meant. And so trying to figure out what telehealth was when I managed to see her for a follow-up, and she made her second oral request at that time. I still was not prepared to take on the responsibility of being the prescribing doctor, but I documented her second oral request. Doing what I felt I could, I discussed options for supporting her and controlling her suffering. She was already enrolled in hospice and had surrounded herself with supportive friends and family. Mental health services were difficult because of the pandemic, and Peggy was too ill to attempt attending a support group. She was not a religious person and so did not desire pastoral care. For Peggy, her choice to continue moving forward with medical aid in dying was about remaining in control of her mind and her body, maintaining her dignity by being able to perform her own personal care and avoiding suffering. She was very pragmatic and decided she had nothing vital left to contribute to this world. She was ready to die on her own terms. So this is where I found myself. My patient was asking me for help, and even though it was legal and within her rights to access a prescription to end her life, I did not think I could be the one to write it. Yet, this was not something I could easily refer her on to another provider for either. She was too far along in her illness for that. I felt like I was abandoning Peggy in her time of greatest need. So sometimes we do things in medicine all the time that cause us moral distress. Sometimes it is for our employers. Sometimes it is for the insurance companies. Sometimes it's for the government, and sometimes it is for the patient. In order to continue doing our important work, we have to find ways to make peace inside ourselves. When it came to Peggy, I was able to come to the realization that what really needed to be done was about her, not about me. But I was the only person who could do what she was asking for. Having established that I was going to walk that path with Peggy, it was up to me to know the way. Unlike Kaiser and Hawaii Pacific Health, where there are dedicated programs to help coordinate assisting patients and their providers through the process, there was no support from the practice I was part of at the time. I was on my own. Medical record documentation and forms were straightforward enough, but finding a second confirming physician and a mental health provider was a more challenging step. So many providers, like me, were hesitant to be part of this process. I actually spent a few days cold calling people to ask them for help. As humbling as the process was, I also came across people and resources that buoyed my efforts. If you do not know about Kokua Mau and everything they do to support people who have serious illness, those who care for them, and those who work in the field every day, I strongly encourage you to check out their website, which is listed here. I would like to give a shout out to Jeanette Koijane, the executive director, who personally spent time on the phone with me, listening to my struggle and directing me to resources. The Department of Health website has a roadmap and all the forms necessary to comply with the requirements of law, which made accessing the steps necessary much easier for me. Here is a list of the forms that are required as you go through the process. And on the right, you can see the final attestation form that the patient must provide to the doctor before the prescription can be written, once the waiting periods and all the other forms are complete. And these are available on the Department of Health website. So Peggy and I managed to complete the consultations, forms, and documentation by the end of September, and I was ready to write the prescription for her. We located the pharmacy that she would be getting the medication from, and for the first time in the entire process, Peggy balked when she learned the cost of the medicine was over $400 and not covered by insurance. It actually took her another 2 months to come back to me and ask for it to be written again. It is useful to know that for some patients, there could be a prohibitive cost involved, and it is best to discuss this up front. Peggy ended up taking the medication the very same day that she picked it up from the pharmacy. So these are the statistics from the first 3 years that the Hawaii Our Care, Our Choice Act has been in effect. And you can see that the numbers are not very high. The number of attending physicians who have written prescriptions is actually fairly low, 21 providers. 70 prescriptions were written last year, with 30 in the years preceding. And then patients who actually died from taking a prescription is listed here. And you can see that the numbers go up over time. That's not because more people are using it. It's just that the prescriptions, the patient doesn't have to use it as soon as they pick up the prescription. They can wait and they can hold on to it until it expires. And so some of those 49 patients could have received their prescription in 2019. We just don't know. I'm sorry, I got those statistics wrong. So those are people who died for whom a prescription was written, and the numbers below are those who actually took the prescription to end their life. So of the 49 who died, 29 had consumed the medication. But there is a time lag. Here you can see the distribution of participating providers, and I would like to highlight the fact that there are no providers at all on Lanai or Molokai. So Hawaii's unique geography and limited number of physicians have proven to be barriers for patient access. This week alone, I have been caring for an elderly gentleman from Molokai who would have benefited from access to this law. Instead, he felt his only option was to walk in front of a car, and now he's restrained on suicide watch in the hospital instead of dying on his own terms. The bills that were brought to the floor during Hawaii's 2022 legislative session were designed to help improve access and wait periods, shortening the wait periods and allowing non-physicians to be consulting and attending physicians or providers rather. Unfortunately, both of these were they failed to advance to a final vote, and so they're still sitting there waiting for consideration next year. Thank you all for your time this afternoon, and I welcome your comments and questions.
Okay, thank you. So thank you for your very honest and transparent, discussion of this dilemma, this challenging thing. And I know it's not been easy to share. So I'm just going to open it up for folks to comment. I was wondering, I see Luke is actually on and you're in counseling. I don't know if you've encountered any of these or any of your colleagues have encountered any of these situations.
Hi there. And yeah, I just wanted to echo Ida's appreciation for your presentation. Really, thank you. And hearing your personal and emotional perspective as a provider, I think is really, really helpful and meaningful. So I myself have not been involved in any of these situations with this sorts of this goal. There have been lively discussions on the Hawaii Psychological Association listserv, and there was a sort of a movement to get folks to sign up, because folks were having hard time accessing psychologists and other mental health providers. So there was sort of a couple folks spearheading it on the listserv, and so there was a number of folks who responded. So yeah, it's a very complex and emotional situation, and appreciate all the folks involved in helping this happen,
Yeah, because I can see how this really might be a barrier down the road. If there's psychologists or other counselors who are not trained, not familiar with, or unwilling, reluctant, and there's not that many of you guys. So
right.
So
And
anyway.
I think one of the complexities to just throw out there and see if other folks want to talk about it too is being depressed is something that is something that we of course watch out for in our profession, and being depressed is not something that a person is supposed to be when they are making this decision, and how complex that kind of a designation can be. Just wanted to throw that out there if anyone has comments or thoughts about that.
Can you speak more about that, Lucas? Because I'd like to hear more about your thoughts about how you determine whether the depression is influencing someone's decision, and how you can imagine, I would imagine it's a very rare slice of society that could be at the end of life without some depression, but still reasonably wanting to end their life. So can you talk about that, please?
Sure. And I think the fundamental, for me, the baseline of what I would be arranging my thoughts and approaches around would be that if there is a depression here that is potentially improvable, then the person's desire to die may not be there when the depression lifts. And so that would be my sort of guiding thought for, is this depression, or does this person who is wanting to die show symptoms of a depression that is maybe influenced by a number of other factors that could be improved in their situation, in which case the depression might lift? Does this person have a long history of depressive episodes or attempts to end their life, which would signal maybe this is part of a longer, depressive symptomology for this person. The key would be, yeah, if certain things could get better for this person, given that they have a terminal illness, given that they might be in physical discomfort, life still be worth living if their mood got somewhat better and they could envision themselves still doing things that they might enjoy, being with people in ways that are valuable and worth kind of sticking around for whatever time they have left. So yeah, I could see that being very, very complex to sort of parse apart in a lot of these cases. I don't know if those comments make any sense, but those would be my thoughts about that.
I think it really does. I was going to add to what you're saying, Lucas and Susan. Thank you again for, not just being transparent, but really helping us to look at our own values, our own beliefs as individuals. I've also struggled with some of the same issues you bring up, and to be able to be out and willing to show that vulnerability speaks a lot to who you are as a person. I think it continues to be a challenge that you pointed out, like for the islands of Lanai and Molokai, there's nothing in terms of resources. And I'm not just thinking about the mental health component, but the providers, the current providers on those islands. And then you have to deal with cultural aspects for those islands, right, Lucas, who primarily are Native Hawaiians. So again, I that has to be explored. I wanted to throw out there, though, that I recently took a training, it was advanced care plan training, and who was in my class was a death doula. So I wanted to know if people had any experience working with a death doula as it pertains to our Care Our Choice Act, because after she shared how she was involved with that process, knowing the person still had to take the medication, I started to change a little bit of my perspective about how they're there to provide that emotional support, Lucas, and to help that person through and to be there to the very end as they're moving through these stages, the transition of actively dying.
If nobody else has anything to say, I really appreciate this this presentation today, but I just want to make a comment. I love to watch vet shows, and so often it comes that there's a situation where a beloved pet, whether it's a horse or cow or dog, cat, it reaches a point where the animal is not going to survive. And it just amuses me that they say the humane thing to do is put the animal out of its suffering. And yet when it comes to the humans, we have so much trouble with allowing, doing the same service to a human being as that we'll do to a horse or a cat or a dog. It's just a comment, but I just think it's weird they use that word. The humane thing to do is euthanize, and yet humans don't think that's humane. It's hard for humans to do. It's just a comment.
I think that tendency stems from the motivation. We don't trust people to have the right motivation behind supporting euthanasia, that they have something else to gain by having this person pass away. The insurance company, they won't have to pay for the services anymore. The family, they will be able to go back to their old lives, or they get the inheritance. And I think that that's the underlying fear behind support for euthanasia. It's the humane thing to do.
But it's complicated when it comes to humans. Yeah, true.
Does anybody else have any experience with this OCA Act?
Yeah, this is Johnny. Yeah, I've had limited experience, and one thing I wrote in the comment too was just about this whole issue about depression or not. It's always difficult, right? But with my limited experience, trying to get a sense of, sometimes it's the folks who are choosing the Our Care, Our Act, or whatever the acronym is, they want to live, but they cannot because of they have this terminal condition. And I think that's very important. People, it's not that they want to die, they are going to die. They just want some control over the process because it's coming pretty soon, as opposed to someone who may be actually having suicidal thoughts. It's a totally different situation. But certainly what I've seen is that it seems to really provide peace of mind and sense of control for people who are in a very difficult position and feel like they have no control. And I think that just speaks to part of the reason why there are fewer people who actually take the medication than have it prescribed. I think it's that peace of mind and sense of control that it gives them. And I think, that's sometimes the only thing we can offer, right? In people who have these really terrible situations. The other thing is, I think the language that we use is also important because, sometimes people refer to it as physician-assisted suicide or even euthanasia. I think it's actually technically those are actions where there's actually a direct action by the physician that causes the death, whereas this is more we're providing the medication and the counseling and things, but we are actually not involved in that final determinative act. And I think that's a really important distinction.
Anybody else grapple with this?
This is Jackie Mock. I was wondering from the statistics that Dr. Christensen presented, some people have the prescription, but they may not actually take it a few years later. So does the law require you to go through the whole process again after a period of time? Is there an expiration period?
No, once the patient has gone through the process, then, and they have the medication, they don't have to go through the whole process again. Ideally, they have a prognosis of less than 6 months. And so it's, not expected that they would live years into the future, but, as we all know, prognosis is not, a perfect process. And so sometimes patients do live longer. So I honestly think it's just the expiration of the medication itself that would limit the person's ability to use it. And even then, if the intent is to, end their lives, maybe even that might not be a limiting factor. But no, they do not have to go through the entire process again.
I think what makes it also complicated, when I've talked to the doula, she said that sometimes, the medication that you're administering to yourself, it doesn't work initially. So it gets, and they're usually, they were surrounded by a lot of other family. And my understanding is you're not allowed to assist the person in administering the medicine if at that point they needed more medication. Is that correct from the doctors out there?
Yeah, so there are a couple of different protocols out there that have been vetted. I don't think that they have gone through, full double-blind controlled studies, but they've been vetted by the doctors on the mainland. And so I think the best strategy would be to use that. And there are 2 pharmacies on Oahu that will fill those protocols for patients. But that definitely increases the likelihood that it will be successful, especially if the patient is counseled by the pharmacist on the order, the sequence, and the timing of the dosing.
Yeah, and this is Johnny again, and I think this points to also the importance of having hospice involved, and oftentimes they're there in case things don't go as planned. But I believe with the new combo of medications, which are pretty staggering doses of things, I think, all of the docs, when you look at the meds, you kind of do a double take and think, oh, that's actually like in grams, not milligrams. But having hospice present in case there's not the anticipated passing, or there's other types of distress that goes on there. I think that's really valuable to have hospice there.
So Dr. Yates, your question brings a question to my mind, is that, so hospice have no problem. I guess there's no conflict here. So hospice agencies can be involved till the very end and with the patient who chooses this our care, our choice. My other question is, what if the person is unable to actually get to the pharmacy himself or herself due to the illness? Does the law require the person to pick it up personally? Or can she sign a statement, have a proxy, pick up the medications?
So in my case, the pharmacist wanted the patient and a support person there to directly receive the counseling. Is it possible they could do it over FaceTime? Maybe, but I think just for the pharmacist's sake and making sure that they're complying with all their requirements, the patient should present in person.
Thank you.
I also had a question as to whether or not there's any data, Dr. Christensen, on the locations of where people, it'd be interesting to know how many people are choosing home, how many people are in independent living, assisted living, or other type facilities, care homes. I don't know if anybody's looked at that. Where are people choosing to?
So care homes and facilities forbid use of the medication within their facilities. So all of these patients have to be either in a home or in a friend's home, because the care homes don't want anything to do with this. I think they're concerned about what it might do to their ratings and whatnot. So now a private care home that's not Medicare affiliated, maybe they might be more open to it. Dr. Wen, do you know any private care homes that might be? No. Okay.
We
Yeah,
don't know if any assisted living facilities ever looked. It'd be interesting.
Yeah, I could look into that, but at least in my preliminary look at that, it's not even the hospitals
Right. We can
allow patients to consume it within the hospital property. So the patient has to be discharged. So even if the hospital is supporting the process, they still require the patient to go home to consume the medicine.
This is Johnny again. I'm with Kaiser, and so one of our navigators had mentioned that she thinks Arcadia assisted living permits it. I never followed up to confirm that. But that's what I heard. And I do know that you're not supposed to do this in a public place, because I was wondering, does someone book the honeymoon suite at the Halekulani and try to do it there? But yeah, you're not supposed to do it in any sort of public setting, although apparently some people have done that. And then, yeah, as Dr. Christensen said, and also kind of, I think maybe touching a bit on what Jackie had asked, I think hospices also don't permit this in the hospice facility, like an inpatient unit, but hospices, the hospices are involved and they can even be present at the bedside, but it doesn't occur in a hospice facility.
So this is Jackie speaking again. I work for Kahala Nui. And our care center side, so including our assisted living, memory support unit, and nursing, we cannot carry out the law in that area. As for the independent living section, like Dr. Yates said, maybe if they go to a hotel, because we're also tied into, we're on Catholic leased land. So the Catholic Church had issued a statement to us that we cannot do it on their land. So, so we're very limited that way. But for our independent living resident, you know, if they go to their family's home, you know, their daughter or son, I don't think we have the right to have any say to that or restrict that.
Dr. Christensen, Sarah again, did Peggy have any support system, friends or close family that could be with her at the time?
Yes, actually, she had a huge friend network, and the friends were kind of rotating between them to help take care of her. And she also had the hospice support and a hired caregiver as well, who would come in and help her with bathing. So she had a huge network. Interestingly, she did not really involve her children in the process. I never, you know, I had spoken with her daughter on the mainland several times, but Peggy did not want me to talk with her about this. And I didn't even know she had a son on Oahu. You know, so there might have been a little estrangement there, but I do now know she has a son who lives on Oahu. But it was her friend network that was with her and supported her through it.
That raises a question about risk management. You know, obviously, if your patient is alert, oriented, and deemed competent, you know, she should speak for herself and she should make decision for herself. But if we have someone who's borderline and there are children who are designated power of attorney, then it gets a little bit more complicated, right?
I think cognitive impairment would immediately disqualify you from being able to make this choice, unfortunately. So yeah, it's our patients with severe dementia who, you know, 10 years ago, if they'd known they were going to end up like this, might have chosen it, but they're not eligible.
You know, in the proposed, this is Sarah again, in the proposed legislation changes, do you know what specific changes were being recommended, especially with reference to the, you know, there's that 20-day wait period, which is pretty long. So.
Yeah, so the recommendations of the law modification were to shorten the wait period to 15 days from 20, and to be able to waive it for someone who is not expected to live that 2 weeks, that if someone was imminent and wanted to be in control of the process, that it could be waived. And then the other component had to do with providers authorizing APRNs to be the prescribing provider as well as the confirming provider. So interestingly, the social workers can, licensed clinical social workers can fulfill the psychiatric assessment and state that this person meets the requirements, they're not depressed. But when it comes to confirming that 6-month prognosis and writing the prescription, it has to be an MD or DO. So it's really limiting, in the one area where we really need more providers.
I think as a social worker, as a licensed clinical social worker, I would still feel very uncomfortable because I don't have the training that a physician or nurse practitioner has. And so it would be really outside the scope of my practice as a clinical social worker. I would look specifically at the mental health side of the situation. But I know what you're saying is, yes, if we could get some of definitely the nurse practitioners approved to do this, it would help.
Yeah, and I think the origins of the law were kind of back 10 years ago before we started using mid-level providers. And now I don't think our medical businesses could survive without nurse practitioners at this point. You know, they are becoming so essential, and so now the law needs to catch up with that.
Yeah. Any more thoughts? Susan, did you have another case you wanted to challenge people with, or?
Well, yeah, the gentleman from Molokai that I mentioned in my presentation, he is a particularly heart-wrenching situation. His 99th birthday was yesterday. And he was diagnosed with a skin malignancy on his nose pre-pandemic. And then when the pandemic hit, you know, it was impossible for him to get the treatment that he needed for the cancer. And so it's progressed over the last 2.5 years. It has eroded into his right sinus, is causing headaches. And you know, so naturally, he's been living with this erosive cancer on his face for 3 years. His anxiety level about what's going to happen to me has gone up. And then in the last few months, he hasn't really been able to take care of himself adequately, you know, getting to the store and getting his food and his meals, you know, so he kind of got depressed and decided that he was going to take matters into his own hands. And we can see a couple ER visits where I think he was trying to see if he could get a prescription for pain medicine, but instead he was referred for, you know, home health services and PT and social worker consult. And so then he decided he'd walk in front of a car, but the car was moving too slowly and swerved and didn't hit him. But he's very clear that, you know, my life is over. I'm ready to die. You know, I have nothing left. You know, he's a widow. He doesn't have children. Widower. He doesn't have children. He does have friends on Molokai that he's been relying on, but they're elderly as well. And he just, every day I go to see him and he's like, I want to die. And he's like, you help it go faster. And I'm like, I can't, you know, I can't help it go faster. And now because he's suicidal, even though he knows exactly what's going on and what he's doing, he's not really eligible for this, you know, for the medical aid in dying. So yeah, we keep trying to figure out how to massage it and, you know, spin the tail so that, you know, we remove that depression aspect and the wanting to die aspect and saying he's at his natural end of his life and, you know, wants to be in control of it. So I don't know if anybody has thoughts.
Is he on hospice care?
We have admitted him to hospice as of yesterday. He was admitted. It's just, where is he going to go? Are we able to get him back over to Molokai where he can be with his friends, or does he have to remain here? So yes, he will have hospice care. But I had to tell him that he couldn't be trying to jump out the window as soon as we took his restraints off, because then hospice won't take him. Yeah.
That is heart-wrenching. I was also curious in your presentation, Dr. Christensen, that you said nobody on Lanai and Molokai. Well, actually, there's one in Molokai, but he can't get it. I wonder if it's a lot of it is Hawaiian values. It's just, yeah, just wondering.
Or just time, the amount of time it took me to figure out. I think the only reason I had the time was because of the pandemic. And
Yeah.
I was doing telehealth, so I was at home. I wasn't, and I had a little extra time to squeeze in phone calls in between. So a doctor on Molokai who's,
Which
got a
is,
very busy schedule and no support for it.
yeah, lack of providers on those islands too.
Yeah. We'd almost need a liaison who could be called from Oahu to go in and support over there, offer support.
Yeah, you raised a lot of good questions were raised here. Thank you so much for doing that, challenging us all.
Yeah. Thank you.
Yeah, and I just want to point out that in the chat box, we have evaluation link. So make sure you click on that link and that way you can get your CMEs for today's session. Sarah had another question. When patient treated for depression is stable, can he then be considered for the OCOCA Act?
Yes, I think, yes, that he can be. Unfortunately, I don't think he will live long enough for that to be better. He would be one of those people who, in that 15-day window, we might be able to accelerate, but yeah, I think it's too late for the law to be able to help him.
All right. Thank you, everybody.
Thank you all for
Thanks for
listening.
joining us.
Thank
Okay.
you.
Thank you.
Dr.
See you
Christensen.
next month.